In a society that often avoids conversations about death and dying, how can we encourage open and proactive discussions about advanced care planning to ensure that the individual's wishes and values are respected during the end-of-life journey? Welcome to Transitions in Care, navigating the journey of palliative and hospice care. In today's episode, we are honored to have Dra Rhodora Ocampo, a compassionate expert in palliative and hospice care, sharing her wisdom and experiences. We will explore the importance of a person-centered care, the significance of advanced care planning, the challenges faced in the hospice space, and the transformative power of palliative and hospice care. Join us as we discuss all these vital topics and discover how all this knowledge can benefit individuals and families navigating the complex world of end-of-life care. Welcome to the Life Doula podcast. Welcome to Transitions in Care, navigating the journey of palliative and hospice care. I'm your host, your life doula, Charity Marahomsar, and today we have a special guest with us, Dra Ocampo, a renowned expert in palliative and hospice care. Welcome, Dra, to our Better Days Home.
Thank you, Life Doula. It's really a pleasure to be here, and I'm excited to address these important questions and provide insights on palliative and hospice care.
Dra Ocampo, share with our audience. I know the backstory, but it's quite interesting. So I want Dra Ocampo to share with you, how did you end up doing more than 30 years of work in the hospice space while your medical subspecialization is ENT?
Yeah, well, I guess that nothing really happens without a purpose, right? So here was I back in Los Baños after 9 plus 4 years of training to become an ENT, and a very single one at that. And so one day, my friend who's a dentist who occupies the clinic next to me says, "Are you doing anything on Sunday?" And I guess, "No, I'm not." "Come with me. Let's go to church. There's an orientation there of some sort." So off we go, and then we said, "Okay, then let's have dinner afterwards." The speaker was Dr. Josefina Magno, who is a Filipina pioneer of hospice in the United States.
Wow.
So she's there, she gives a talk, and then the organizers pass around a piece of paper, say, "Who wants to volunteer?" And then, volunteer. But everybody around me was like signing up. So I said, okay. So
sign up na rin.
So, sign up. And then you have to put your profession, doctor. Okay, Rhodora Ocampo, doctor. Del Rosario pa ako nun, dalaga pa ako. And the organizers looked at who volunteered, and they saw me, doctor, but they did not know who I was. So they naturally assumed she's a young doctor and a new one in the community because they didn't know me. So they called me and said, "You signed up for this, and can you, have a meeting with us so we can put up our own hospice care?" And that's it. And that started the ball rolling. I guess I was called and I just answered that call.
Yes.
I literally did not know anything about hospice and palliative care. They gave me a book and they said, "Study." Okay. And that's it. We started doing
years,
home visits, and 30 years. And it's already part of my life.
Yes.
I guess.
That's a beautiful backstory, Dra Ocampo. I think really was meant to be in my life, because as I was looking for someone to mentor and guide me as we were planning to do the hospice, our dear friend introduced her to me. And I was surprised that we had to meet for mga 2 meetings. The 2 meetings, she had a lot of questions. Sabi ko, para akong nagre-revalida kay Dr. Ocampo. And to cut the long story short, it was really an alignment of what we both wanted to do. No? So, a beautiful coincidence that led us to here. Dr. Ocampo, let's start by challenging the common perception of palliative and hospice care as merely end of life. When you're in palliative care, you're dying. Can you share how embracing these care transitions can actually enhance the quality of the patient and their families?
Okay, let me just talk very quickly about transitions, because this is where palliative care really is most needed. So we call it transitions in life. So here you are leading a very normal life in your corporate life, and suddenly you get diagnosed. This is a transition. And here you are doing your surgery and being told that you need more than surgery. That is a transition. And here you are having chemo or radiotherapy, and suddenly your doctor says, you're well, but you're not really going back to your normal life because everything has changed. That is a transition. Or on the opposite end, your doctor telling you that, well, chemo and radiation will not work anymore. So what do we do now? So that is transitions. So it is these very crucial transitions that hospice and palliative care is very important. Because in this area is when you start to have questions, when you need to make decisions, and when you take stock and look at your life again. And this is where you need to talk to somebody probably, because not everybody can do it by themselves. And this is where palliative and hospice care comes in. Take note that end of life is just at the very end. Okay. Dulo siya dulo. That this whole spectrum of our lives where transitions come because of a very big change, this is where the value of palliative and hospice care come in.
That is such a beautiful explanation, because a lot of times even the word transition is equated to dying. Okay? And what Doctora has explained is at every point and juncture in your journey when you have health challenges, all these movements, all these changes are transitions, right? And in these transitions, that's when hospice and palliative care comes into play. So, maliwanag, it's clear that, when you hear the word palliative care, it is not equated to end of life. As what Doctora said, the end of life is way down, the road. So, I believe that we have to over-communicate. So, I'm paraphrasing this question. How can we shift the narrative around palliative care? Because I think there's a lot that we need to do. How can we shift the narrative around palliative care and hospice care, moving it from being seen just as end of life to a means of enhancing the quality of life during difficult moments of your health journey? Provide us some insights in this one.
Certainly, Charity. So to redefine perceptions, we must emphasize that palliative care is about the living. Take note. Again, I will repeat for emphasis. It's about the living fully despite a serious illness. It's about enhancing quality of life, managing pain and symptoms effectively, and offering support beyond the physical aspects. Education and open conversations are key to changing the narrative. Let me just share a quote from Dr. or Dame Cicely Saunders, who is the mother or the founder of modern day hospice. And she says this very beautifully. You matter because you are you and you matter to the last moment of your life.
Wow.
And we will do everything to help you live until you die. And that has been the mantra of all of us who are in the palliative space.
I love that. That until the end of your life, it matters that you live, right? And if we capture that, we can now say that palliative care is really about the living. It's a choice we make to probably forgo of life prolongation, but instead, live the life you want to live. Be able to be functional, be able to do gardening. Doctora lives in Los Baños, kaya naisip ko yung gardening. Or be able to do stuff that you want to do. And tell yourself, I am still living the life I want to live. Very interesting. Let's continue with our next question. In what ways does a person-centered approach to palliative and hospice care support the emotional, physical, and spiritual well-being of the patients and also their loved ones?
Okay. A person-centered approach is the very heart of palliative care. So we recognize and honor the uniqueness of each individual. None of us are the same. So we cannot have treatment or management that's like de cajon.
Yeah.
It's not a recipe. So we address their physical, emotional, and spiritual needs. This is a very whole-centered approach. And it means involving the patients and their loved ones in the decision-making, promoting open communication, and tailoring care plans to their preferences. And we have to honor these preferences by nurturing emotional connections and providing holistic and pain and symptom management and honoring their spiritual beliefs.
Yep.
We can support the overall well-being of the patients and their families.
That's an interesting note, no? Honoring their spiritual beliefs. I had an end-of-life patient based in California, and she is of another religion, and she doesn't really believe in many things, So when I was brought in as end-of-life doula, I had to understand what their religion practices. And I had to design the end-of-life program to make sure that that is included, right? Like, it will take so much time if she passes on because they don't believe in cremation, right? So all of these things we need to take into account, and that is what a person-centric approach in caring for the patient and their families also require. I mean, even, Doktora, the capabilities of the family to care, right?
Yes.
Baka ang may sakit is a daughter or the son, and the parents are already old. So therefore, you cannot subject the patient to very harsh or rigorous treatment because no one will care for the patient, right? Doctora, let's explore this question. How can we ensure that patients have access to comprehensive pain management and symptom control at home? Because I know that this is the space where you're in, to be able to maximize comfort and quality of life.
Okay, home care is actually one of the models of providing palliative care for patients. Personally, I prefer it as well because in the comfort of your own home, you are in control.
Yeah.
As opposed to in a hospital where the nurses and the doctors are in control. You can set your time in the home where you want to sleep or who you want to see.
Yes.
If you say, I don't want to see this person, then shut the door. Nobody's going to question you for that. But again, the challenge in our homes would be like, how do we communicate with the care team? who's taking care of you in the hospital and ensuring that there is a continuity of care. And therein lies the challenge of home care. Also, you don't have insurance at the home. So
Yeah.
all of the finances are going to have to come from an out-of-pocket expense.
True.
But be that as it may, if you have a good palliative home care team, then certainly the care can be provided.
I also agree with that. With most of my patients, I recommend home care because it limits the possibility of secondary hospital infection, acquired infection, right? So there you go. That's really very important to consider. Doctora, you and I have been going through further studies and we rely on technology. Our classmates are in different parts of the world, right? Now that we have all these innovative technologies and telemedicine, I recall during the pandemic, telemedicine was such a big thing. What support in terms of remote monitoring and communications for patients can be extended in the palliative and hospice care at home?
Well, technology has certainly positively impacted palliative and hospice care. In fact, during the pandemic, I was actually able to see more patients because I was online, and my patients came from as far as the north in Tarlac in Pampanga to as far south as Cebu.
Wow.
Because very few of us were going online during that time. And it really allowed us to monitor the patients, monitor their pain, monitor their symptoms, and learn to work within that situation where there's limited access on all sides. But just to share this story, because I love this story, I had a patient in Parañaque. So actually was working with him when he was in hospital. He was intubated in hospital. He had pancreatic cancer. Daughter came home from the States and got me online because, everyone was always online during the pandemic. So, you could really answer most messages in a very timely way. So my dad doesn't want. So, and then I said, well, then just tell your doctors to remove the tube. Of course, the doctors didn't want to remove the tube. Her dad removed the tube by himself. And lo and behold, he was okay without the tube. So they sent him home. And I said, good, because then in the home, I will be the one in control of the care.
Yeah, sure.
So we were able to do it. We controlled his pain. I was able to get narcotics for him through various sources, sent the prescription online and all of that. And then because he was feeling well, he suddenly says to me, Doctor, I want to go home to the States. That's where I want to die. And I said, sir, so it gives me all these problems. Okay, then, and the daughter says, can we do it? Doctor, I said, let's try. So let's control the vomiting. And I discovered a drug that will control vomiting for 3 days.
Enough for him to fly.
Enough for him to fly, because that was my problem. How do I give him a anti-vomiting medication that's going to last the whole time?
Yeah.
Because I cannot have somebody giving IV on the plane. I don't think the airline will allow it. Anyway, so I discovered that, and then I said to him, you have to fly first class. And he said, no problem,
Wow.
Doctora. Okay. So everything I said, no problem. And he did fly. I had to issue a medical
Clearance,
certificate so that the airline will allow him to travel. I said it's a good thing that there is a mask so people will not see your nasogastric tube because he had a tube in his nose. So always wear your mask. Don't remove it because people might be afraid of you. I had the daughter bring certain medicines that he might need in the airplane. But lo and behold, he didn't need any of it. So when they landed in LA, picture, selfie agad, send to Doctora. We're here.
All technology.
All technology until he was able to get to Houston. And in Houston, he went into a hospice facility.
Yeah.
So, and this all happened
With the help of technology. Yeah, I remember a story where I involved Doctora in one of my patients' end-of-life care. And again, technology came into play when the wife told me that he wasn't doing well. Doctora went on Zoom, I think not even on Zoom, on
Messenger.
FaceTime or Messenger, and she was able to see the patient up close, and Doctora was able to give me certain timelines based on what she saw. So really, technology bridges a lot of things, and we hope to be able to leverage it more and more in the next coming days. So this is what you and I believe in. It takes a tribe to take care of a patient. It cannot be just a singular doctor or a nurse. It takes a whole community of caregivers. Now, talking about caregivers or love givers, how can we adequately support these caregivers through what you're doing now? You have a daycare center. What we're going to do in better days, we're going to have a daycare center. How can we support them emotionally and mentally by providing all of this from the care at home?
You know, when someone is sick, it's actually the person who takes care of them who's the most stressed. Not the patient, because the patient is usually just lying down and waiting for what happens to come next. And usually
Yes.
the patient will say, bahala ka na. It's up to you, especially if it's the husband who's lying down there. It's always go to the wife and says, you take care of it. And so you have this stress. Sometimes you don't think you have stress, but you actually do, because all of the decision now comes to you and
Yes.
taking care. Good if the patient is nice and, follows, but if the patient is always complaining and not following the doctor's or whoever's advice, it can be very challenging at times. So that's the concept of the daycare or the respite care. So what we do is we take your patient away from you for a day.
Wow.
Okay. And then we let you, as the caregiver, your me time, your,
Take care of
your
yourself.
self-care time. So we allow, go ahead, go shopping, go
Get your
to the
hair cut.
parlor, get your hair cut, get your hair done, watch a movie, or just, chill wherever you want to. And we're going to take care of your patient so you don't have to worry about him not eating or not taking his medicines properly, because we're going to do that for you and while you do your thing. And it's very, very important to do that, because not to be so morbid about it, but there's so many times that I see patients, the caregiver, the first one to go, even
Wow.
before the patient.
Yeah, that's so timely because I have a new client for grief now. It was the dad taking care of the mom, and everybody was focused on the mom, and they forgot the dad. And the dad was, had a heart attack. So maybe the stress of worrying about the mom.
Yes.
So there's guilt now because everybody was focused on the mom. Wow. Self-care for better patient care,
Yes.
I think, is a concept of a daycare or a respite center. Interdisciplinary teamwork is key to holistic care. But how does it play out in delivering palliative and hospice care at home? Doctora, how can we optimize all of this for the benefit of the patient? Like, you have several doctors probably in the team.
Well, collaboration and interdisciplinary approach is very fundamental in palliative care. The doctor is just one player, and in fact, not really the biggest player in the team. For me, the biggest player is usually the nurse or the caregiver, because that person is with that person
Yeah.
24 hours,
Yeah.
24/7 maybe. Doctor just comes in for a short time. And the other important ones are the ones who provide the other types of care. In palliative care, we have a concept called total pain, where the pain of the patient is not just physical, but it's because of many other things like Okay, physical, it can be because of the disease, it can be because of a side effect of your medication, it can be an emotional pain, a psychosocial pain, a spiritual pain, financial pain. So we have to address all of those causes of pain in order to really, really help the patient. So you need all those types of people to help you with that.
Wow,
It's
it
really a
really
tribe.
takes a tribe, very important, I guess, for our audience to know that, you can have a team, both medical and non-medical, to be able to support uh, your loved one who is sick. So you can also journey with them and not do this alone. Let's bring this closer to home. Doctora, what have been the challenges in our culture in really leveraging the hospice care? No? The thought of hospice care in the Philippines, I know it's opening up, but I'm sure there are still challenges.
There are many. When we were starting, we were called the angels of death in the community. So it was really hard because like we were going house to house and asking if there were people who were seriously sick. But we don't do that anymore, but there's still many challenges. First challenge is the patient himself. If the patient does not accept what he has. And so if you say, we're going to refer you to palliative care, he's going to say, absolutely not. I'm not dying. The families themselves may not be accepting because
True.
they know they're going to be asked difficult questions.
Yes, true.
And I've had some consults like this, they don't want to go back because I keep asking the difficult questions and trying to get them out. And if they're not ready for it, it can really be hard. Of course, you have your doctor factors. The doctor who does not want to talk about death.
Yes.
The doctor who will not accept that whatever he's done for the patient, it's just up to that point.
Yeah.
Okay, so that's already a big factor. You have your hospital factors. What do I mean? Most hospitals will not admit a patient if the patient, is sort of not in a good way because it's going to add to their mortality statistics.
Wow.
And we are measured by that. Hospitals are measured by
That's
that.
sad.
Or if they think that, I'd rather give this bed to somebody who's going to really get well as opposed to somebody who's not.
Wow.
And this is especially true for resource-poor settings. Government hospitals. You'll not give the bed to this dying patient. You'll give it to somebody who's like, maybe needs some surgery or whatever. Then you have your access to medications problem. Access to morphine. Right now, we don't have morphine in the market. So my patients have
it's been a
so
month.
much
It's been several months, no?
Yes, we are not purchasing. And if you look at the statistics globally on how much a country purchases morphine, there's a graph that shows we're just a teeny bit blip on that graph. And it's really very disheartening.
Morphine and other opioids have been scarce in the market the past several months, right?
Yes. And it's very hard. Even government is not purchasing.
Yeah.
Before, I was able to get morphine from the Department of Health. Now, none.
Yeah.
And of course, the other barrier to the development or the continued to hospice care is PhilHealth reimbursements. PhilHealth does not reimburse home care. You need to be in the hospital to get your PhilHealth benefits.
True.
Whereas if you look at it economically from the Bezos's point of view, you actually have a minimal cost if the patient is in the home for these kinds of patients as opposed to hospital, where your medical bills can be blow up.
Wow.
So those are the factors.
There are many barriers pala, no? Many, and there's a big barrier there on government support, which is a whole gamut of issues altogether.
And we don't want to go there.
Yes, we don't want to go there. I'm actually avoiding social media because of that. Thank God for social media managers. I don't have to look at every news that's on my feed. A lot of people think hospice care is just a lurking industry. I learned this when I started going into palliative and end of life, I learned that it's a whole industry altogether. It's been there. Can you please share with us how it has evolved in the Philippines and globally?
Okay. Globally, hospice started in 1967 with Dame Cicely Saunders.
Woohoo! 1 year
Okay.
after I was born.
So the oldest hospice facility is actually in London called St. Christopher's. And so she's a story in herself. But in 2004, we have this World Pain Day by the WHO where they say that the relief of pain is a basic human right. Okay?
The relief of pain is a basic human right.
Okay, we should not be suffering from pain because it has to be diagnosed properly and treated properly. So globally, hospice palliative care, it's there and well entrenched in the healthcare systems of the developed countries like the United States, United Kingdom, and closer to home it would be Singapore.
Yeah.
So there's proper reimbursements, the subspecialties fully recognized
Yes.
by the medical societies. So if I just hone in close to home, not to age myself, but I'm the only one left in the original group that started palliative care in the Philippines in the early 90s. Okay?
Wow.
Only one left because some of them went for abroad and some of them changed courses and shifted focus. So that's me, the oldest one. But at that time, we only had NGOs. So there was no training, there was nothing. As I said, I was given a book and I just had to learn it by myself. And well, eventually some people came and taught me, but it's there. But now we have almost about 4 or 5 fellowship trainings already in palliative care, and there's a whole lot of us. But by law, what we have is called the Universal Health Care
Yes.
and the National Cancer Law, which stipulates that there must be palliative care services in every barangay.
Wow.
And that palliative care is part of universal health care.
Yeah.
That has not transitioned into actual,
Yes.
but there is always hope because it's in the law and I never lose hope. That's what they always tell me. I'm a pure optimist. Yes, I have to be optimistic because there is nothing else that, you know, the opposite of it is just not acceptable.
Yeah. And this is also the reason why Dr. Ocampo and I are working together. We cannot wait for the system to provide a real hospice facility. I was struck by Dr. Ocampo's question to me when she was asking me before she said yes to help me in putting up the hospice facility that we are about to build in somewhere up there in Tanay. Her question to me was, is this a non-profit or a profit hospice? And it was very clear that it was going to be a profit hospice, leaving room for accommodation of indigents. And her response to me really struck me, and she said, it's good that it's a profit because we cannot improve the facilities. We cannot upgrade the salaries of our people if it's nonprofit, which is really such a relief having her in our team because, as she said, she's the only remaining one. And while we know where we want to go, we need someone to help us navigate this terrain. A first real hospice facility. Doctora, will you indulge me in asking a personal and a hard question? Doctora, do you have a vision of how your old age would be? I'm talking about your advanced care plans.
Oh, well, I certainly will not have a lot of things done to me if I get in an accident, or that's very clear. Even now, even if I have my young kids, I've already told them they are, they know what I do. So that's that. And when they asked me, like, how come I'm doing this up to now, and I said that I have to do it because when it's my time, somebody has to take care of me, and somebody has to understand what I want, and
Yeah.
somebody has to understand what palliative care is all about. So if we don't do it now, when it's my time, baka I'll have a hard time getting there.
Baka you will be the one to teach pa, no? How you want to be cared.
Yeah.
Advanced care planning is really important. A lot of us do not want to do it, but that question was really for all of our audience, young or old. If you are young, you need to do advanced care plan for your parents. If you are a parent entering your, what you say, the golden age, you also have to talk to your children like you did for advanced care. Doctora, thank you so much for being such a gracious and generous guest. Some of you may not know, but I kept saying it. Dra Ocampo is our medical director at Better Days Wellbeing Center. She's helping us navigate this terrain of putting up a hospice. So thank you so much, Doctora. Thank you so much for being here always. To our dear audience, today on Transitions in Care, Navigating the Journey of Palliative and Hospice Care, we've delved into the world of compassionate support for those facing illnesses. We've explored the power of empathy, the importance of comprehensive care, and the need for human connection in the face of vulnerability. As we wrap up, let us challenge the prevailing narrative surrounding death and dying. Let us prioritize, as Doctora said, the quality of life, dignity, and compassion in our care. Together, we can create a world where palliative and hospice care is accessible to all who need it. According to Doctora, in every barangay we should have, where we champion the person over the illness. Thank you for joining us in this enlightening journey. Stay tuned for more enriching conversations here at the Life Doula podcast. If this is something that has helped you, share it with your loved ones or with your friends. Remember, always choose joy, heal strong, and stay healthy.